Our next talk is going to get a surgeon perspective on increasing access. Also at the Hackensack, this is Dr. George Mazpule. Let's cue it up and learn more.
Hello everyone, my name is Dr. George A. Mazpule. I'm from Hackensack University Medical Center, and I'm part of One Surgical Specialists. I'm extremely excited I was given this opportunity to talk about our group's experience and how we expanded access in a general surgery division at Hackensack University Medical Center and kind of how we did it. So where I came from, I went to the College of New Jersey for undergrad, ended up going to Rutgers for New Jersey Medical School, and then stayed there for residency. And I then ended up doing my fellowship in minimally invasive surgery at Hackensack University Medical Center. And I was extremely lucky to be offered a position to join Dr. Stephen Pereira and Dr. Adam Rosenstock. Dr. Stephen Pereira is a pioneer in robotic general surgery. He was one of the first robotic general surgeons in the state of New Jersey, and Dr. Rosenstock joins him shortly thereafter and is also a pioneer in his own right. So just to go to the end of our experience, currently this is our variation in our types of cases that we do from 3 p.m. and on weekends. As you can see, there's a wide mix of what we do, and it entails all aspects of general surgery. We do inguinal hernia repairs, which are mainly incarcerated. We do ventral hernia repairs as well, which also a few of them are incarcerated. We do a lot of cholecystectomies for acute cholecystitis because we really do truly enjoy the benefits of ICG and Firefly technology that a robotic platform does offer. We do different types of colectomies, which I got into, and we do a mixture of other various cases. And in total, 22% of our cases were done past 3 p.m.s or on the weekend. So this is a list of the cases that we do perform. Cholecystectomy, like I said, with this we've done a few cholecystectomies and CBD explorations, which are done completely robotic and robotically assisted. We've done different types of colectomies, like I said, like Hartmann's procedures, repair perforations from colonoscopies, right colectomies for intussusceptions, obstructing colon masses, some perforated diverticulitis with abscess drainages that were not amenable to interventional radiology, and with peritoneal lavage. We've done incarcerated hernias of all types. We've done a few gastric volvulus cases as well. We've done some perforated ulcers when the robot was available, and we've done splenectomies. And of course, don't tell anybody, but we've done some appendectomies when we were called for them, and it happened to be during our block time. In my first year, I had a lot of add-ons. A lot of these add-ons went in the afternoon or late at night. I did all these cases laparoscopically, rarely open. But looking back, a lot of those laparoscopic cases could have been done robotically. I probably would have had better outcomes, or they definitely would have been much easier on myself. But because of the culture that was in our hospital system and in all hospital systems at the time, robotic general surgery was not a thing after hours. So I didn't even think that I could ask for the robot for these cases, but I wish I did. So a few months into my attendingship, I had an epiphany. And our epiphany was this. It was a patient whose BMI was 50. He presented to the ER with an incarcerated, maybe strangulated incisional ventral hernia. He did exhibit a lot of abdominal tenderness. I took him to the OR emergently. I reduced his small bowel pretty easily, laparoscopically, and all the small bowel was viable. But then I was faced with fixing his ventral hernia. The defect's around 5 centimeters in width. Now, I struggled a lot trying to fix it laparoscopically. I did most of it laparoscopically, but I did have to convert to finish the rest of it due to his body habitus. And I was converting, and I told the staff to convert. I looked to the left of me, and I see the robot just sitting there, undraped. And it was definitely giving me a certain finger. Because I was looking at the robot, I thought to myself, why am I not able to use a robot right now for this patient? This surgery would have been made much easier if I did. I would have prevented an exploratory laparotomy. And because of that, I feel like my patient received an inferior surgery, and that's where 24/7 robotics started. Thank you to Dr. Steifelman and Dr. Pereira. Because of their support and their vision and their open ears, Hackensack now has a 24/7 robotic surgery program. First thing I did was talk to Dr. Pereira, my partner, my boss, about what happened in that case, and he agreed with that because he has many similar cases with the same issues, that the robot could have definitely been much more beneficial. So I spoke to those in charge, starting with Dr. Pereira, and then into Dr. Steifelman, the director and chief of robotic surgery at Hackensack. So as we approached Dr. Steifelman, him being a urologist, we explained to him our case that was an incarcerated ventral hernia, and I would have been able to do this case robotically and not have to convert to open if the robot was available after a certain time, but I was not allowed to use it. So that's where 24/7 robotic surgery started. So our plan of attack was pretty simple. We engaged our administration initially, and then we developed a grassroots campaign of all the surgeons and nurses from the ground up, and then we tackled these operational hurdles that we've recognized. Our group had a non-stop open channel of communication with the administration. We incessantly fought to have the ability to have the robot available for our add-on cases. We kept following up with the administration after that. We discussed specific cases with them where the robot would have decreased the morbidity and length of stay. A very common case that we brought up to them, and a very easy case to understand, is an incarcerated hernia. And it could be an incarcerated hernia of any type, inguinal or ventral. But those are definitely done much more easily with the robot. We spoke to them and really told them that if the robot is available, the convert to open rate will be much less, and then there were multiple other cases that were also added onto our argument. So then we focused on the opposite end of the spectrum, and we built a coalition of advocates to start a grassroots campaign from the bottom up. These people included Dr. Stiefman, Dr. Pereira, and Dr. Rosenstock, our other partner. It also included James Egan, our CSR, and robotic surgery coordinator Vivian Kofer. Without James Egan or Vivian, none of this would have been possible. All these people were instrumental in really developing a successful 24/7 robotic program and developing a successful pitch to the administration. And then we found other stakeholders that were outside of the OR, and we also had them spread the message. Mainly these were our floor nurses. As our patients that were admitted or had to be admitted, we spoke to these floor nurses and told them and explained to them how these patients are doing better because we're able to do them robotically, and they realized these benefits. We showed them the incisions, and we showed them exactly their outcomes and how quickly they're leaving the hospital and their pain scales, and they bought in as well. We then recognized certain operational challenges that we had to tackle and solve in order to implement our 24/7 robotics program. They were diagnosing the status quo and trying to change it, dispelling misconceptions, and creating a new culture. The status quo was that any add-on general surgery case was to be done laparoscopically or open, not robotic. However, our group still kept asking for the robot to be available. And when we did ask, the most common response we got was why they need the robot. And our response to them was, why not? Another issue we came across was if the robot was available, there weren't nurses or surgical techs around that were certified in robotic surgery to help us with the case. So we would have to do a case in a robot room with a robot sitting there, but weren't allowed to use it because these nurses and staff that were helping us weren't trained. That was fixed easily. I congratulate James Egan and Vivian Kofer and the OR administration for setting up a very successful program that's probably the most popular training program for our nurses and OR staff today. On a Saturday, they invited all the nurses and staff from the OR, they gave them CEU credits, and they all got robot trained and robot certified. So now most, if not all of the staff is certified to help us with robotic cases, so staffing is not an issue. Our next step was then dispelling misconceptions. The most common misconception we had in the beginning was that the robot takes too long to set up and these cases take longer, and that was false. So in the beginning, I helped set up the robot, I helped roll in the robot to dock with the nurses, and I helped pick my instruments, and I still do that to this day. We also use less instruments. In an inguinal hernia, we use a mega suture cut, and we use a forced bipolar or a fenestrated bipolar instead of a hook artery or scissors. And we bring that up to the nurses so they realize that we're using less instruments, so there's less instrument changes. Our instrument baskets have also trimmed down to bare bones to exactly what we need, the total around 20 or 30 instruments that we got rid of all the excess that we did not need, so there's less to count. We also have residents and fellows that we have that we train that are all first assist certified that help the nurses if they're scrubbed in, and if they're not scrubbed in or if they're on the console and we're scrubbed in, we help the nurses. Then afterwards, we share nurses' personal stories of patients that went home the next day that they were personally a part of. For example, I will call to a nurse, hey, remember that sigmoidectomy we did the other day with transrectal extraction? Well, he went home the next day and he passed gas the next day and he's doing very well. So thank you so much for helping us with that. And they were very appreciative of that, and it also makes them realize more the benefits of robotic surgery, because that wouldn't have been able to be done open, maybe laparoscopically, but it's definitely very easy to be done robotically. The culmination of the prior two steps results in our final and most important step, and that is creating a new culture, a culture that aligns with the hospital mission of improving care. And now it is a true belief amongst all of us, amongst all the staff and all the administration at our institution, that robotics improves care in general surgery cases, and especially in general surgery emergency cases. We also celebrate our teams that were a part of this process and help us get to where we are. We take our staff out to dinner, we invite them to conferences, and we also give them a lot of feedback and constructive criticism as well. And as I said before, we create incentives for our staff to be trained. Our staff needs CEU credits, so we created this Saturday training program that Jamie Egan and Vivian Kofer have captained, and it is an incredibly popular program, and that nurses and staff keep asking for more of these to be held throughout the year. So this all started with our private 3-person surgical group initiating a change at Hackensack University Medical Center by bumping it up to Dr. Pereira and Dr. Steifman in administration, and we changed the culture at a hospital that has over 8,000 employees and 1,600 physicians. To now, we have 24/7 robotic access. All the staff is virtually trained to assist in robotic surgery. And the most common question we get now is not why are you using a robot for this, but why aren't you using a robot for this? So these are our current case numbers right now. These projected numbers are actually very similar to the real numbers. So right now we did 470 cases after hours. So some of these cases are elective that ended up going late, but still, if the policy wasn't in place that we're allowed to do these cases after a certain time, these elective cases would have been done laparoscopically. And you see, as we're going up every year, in 2017 there was official policy in place to allow robotics being used all the time. But we were doing that before. As you can see, in 2015 is actually when we started, and it started ramping up and until the 2017 policy was officially implemented. This is our projected volume. So as you can see from general surgery standpoint, just last year we did 100 cases, just our general surgery group after hours. Cholecystectomy, ventral hernia, inguinal hernia, and cholecystectomy resections were the most common. And as you can see, urology as well does a lot of cases after hours. As they are able to book 4, 5, 6 cases in a row in one day, and they're able to operate until midnight for these elective cases. This is a good slide showing that robotics during the day and robotics at night has no difference in consult time or in cost. We do the same exact surgery the same way, whether it's day or night. So some most important takeaways from our struggle and our fight to have 24-hour access at Hackensack University Medical Center is: number one, engage your administration. Show them data, show them your outcomes, show them personal patient stories, and tell them how much worse the surgery would have been or the outcome would have been if the robot was not available. I showed personally pictures of ICG. I showed personally pictures of obese patients and video of me suturing that defect robotically, which it looks very simple, but I'll tell them laparoscopically open would have been much more difficult with much more morbidity. Second, build a coalition of support and help educate that coalition. So the coalition includes scrub techs, nursing assistants, your circulating nurse, your coordinator, which is Vivian Kofor in our case, your CSR, Jamie Egan, the actual surgeons performing the surgery, and then the administrators above that, from the director of chief of surgeries, all the way up to the CMO, all the way up to the president. And all of them got involved to help make us one of the most successful 24/7 robotic programs in the country, from what we heard. And the third is persevere. If you don't persevere, and we would have gave up early, none of this would have happened. It really took us multiple attempts to get robotics involved in general surgery cases after hours in the beginning. We were told no many times, and then we were asked why no. And then each time they gave us a reason, we tackled those reasons one by one in a very nice way, without any attitude, and with data to support our beliefs. Hey, Georgie, where's your hernia?
Right here.
All right, who's going to fix it?
Papa and Dr. Pereira
Uh-huh.
and on the wall and stuff.
Oh, yeah? How are you going to fix it? With what?
The robot.
With what?
With the robot.
The robot? What does the robot do?
Do the robot surgery like this.
Oh, nice.
Now I want my legs today.
Okay. Thank you very much for the opportunity to speak about our experience of developing a 24/7 robotic access program at Hackensack University Medical Center, and I look forward to a Q&A session. And of course, let's go Giants and let's go Yankees.
George, great talk. I'm not sure about the Yankees. I mean, we're in Boston here, but I'll let it pass. So what do you think on, so we've done expand access in the last couple of years. I have to say that my first 1,000 cases was really challenging. Doing these cases after 3 p.m., going into late nights in the weekends, you usually don't have your team A, you have probably B or C or whatever that you call. And usually the very difficult procedures, they're the toughest. I mean, the gallbladders. I had to convert to open many times. I've had going in to do a robotic ventral, and I go in and see a dead bowel. So I actually was fortunate or unfortunate to be dealing with very challenging, tough cases and conversion. And these outcomes not really as glamorous as people might see. And the length of stay, not much control. This is the patient you see for the first time. And even the case mix payer is not as glamorous. This is probably could be not the best insurance. So how was your experience with these? And is it similar to me here in Boston, or is it a bit different?
In the beginning, it was very similar, but we quickly fixed that. And the most important thing is training. We got all our staff trained very well in the beginning. And all our staff really bought into robotics being better for the patient in an emergency setting. So that made it easier for us to train them. Also, we have a residency program. So for all these cases, there was a night float system. So we got a mid-level resident to assist us. And now we have our own fellowship as well. So he comes in each time we have an emergent case if he's on call. But the most important thing is training. A lot of our nursing staff does stay late. And they're there from 7 a.m., sometimes to 10 p.m. if they're able to, and they work overtime for us, knowing that we need their help. But still, the night staff at Hackensack is very well trained. So if you don't have a really well-trained staff, I agree with you. It makes the surgery so much more difficult. But again, in these cases, you can also use a fourth arm, so you don't need a good assist at the bedside, per se, for some of these cases. And if you pick your instruments in the beginning and you limit which instruments you use, that makes it easier, too, in the night staff. But I think number one thing is training.
Another thing is, I thought me as a surgeon was one of the biggest obstacles. My experience at first was not that good, and tackling this difficult operation was a bit of a challenge. So what would you say to these folks who don't have that much vast experience in robotics, or even just not vast experience in general surgery, and they want to tackle this expand access after hours and evenings, and they get challenged with this operation? Because I know teamwork is important, and then you touch on the nurses, the staff, everyone. But I think one of the biggest obstacles, we as the surgeons, how can we tackle these massive or big operations or more challenging operations?
No, I agree with you. I think it's very important to start doing these robotic emergency cases maybe during the day. When you're on call during the day and a case comes in and you could bump yourself, you could do a robotic, kind of like a Hartman's or something like that. That gives you a lot of good practice and training. So you're doing these emergency cases with the A team. And then once you get comfortable with that, you can start expanding those to the nighttime. You could do them laparoscopic or open if you're not comfortable with them, doing a robotic with the team at night, and if you're not comfortable with yourself. But I think it's very important to start doing these cases during the day as well when you're on call for the ER. And that really helps you to get to do it at night.
And how about mentorship? I mean, I remember at first and still till now, I do ask my senior partners or the folks at the hospital to help me out in these challenging cases, and sometimes they're not there. So I would let them know, hey, I'm doing this tough case at this afternoon, this evening. Do you mind if I call you for advice or ask you to come in to help me out with anastomosis or questions or concern? How was your experience getting a mentorship in this challenging expand access after hours weekends?
I'm very lucky. I joined a great group with Dr. Pereira and Dr. Rosenstock, and we act as a team. If one of us is on call and we call on somebody else, one of them, to help us, we come in right away to help each other. During the day, there's always a couple of us there anyways to help with difficult cases like Nissens or very bad colectomies that we know that had long-standing diverticulitis are going to be tough. We're there to help out. For example, if Dr. Pereira is doing a colectomy or Dr. Rosenstock, I'll try to be around if I'm free to do the anastomosis, to help with the transrectal extraction, to do the tap lock, stuff like that to help out. At the same time, we have a PGY4 resident and also our own fellow on our team at all times. So they're either scrubbed in first assisting, so allows another attendant to come in to help with the difficult cases. But I think you made a great point, Youssef. You have to find a mentor that's done this before. And I'm very lucky that I joined a group with my mentor, Dr. Pereira and Dr. Rosenstock. They've been doing this for years. And without their support, we wouldn't have had the success of the 24/7 general surgery program as quick as we had.
Hey, George, I got a question. You use Firefly ever?
No, I saw it on YouTube once, I think.
Tell us about how you use it for gallbladders, perfusion. Thank God Firefly's in Boston. I wasn't going to come unless they had it, so I think that's why Youssef has it. But no, tell us a little bit about your use of fluorescence imaging.
Do we have another half an hour to talk about this? I got to go on
You
forever.
got a good solid 2.5 minutes.
Yeah, you got to.
Perfect. All right. We use ICG for
1 minute.
everything, and we're still using it. We're still looking for ways to use it even more.
Yeah.
We use it in the ureters for sigmoidectomies. Our urology friends do a cysto and place it in both the ureters. It lasts for hours, and it's great. You don't have to dissect out the ureter sometimes. You can see it right when you click on Firefly. We give it to all our gallbladders in the pre-op area if they're outpatients or on the floor if they're inpatients. We use it to test perfusion or anastomosis as well. And we want to use it to look for lymph nodes in our lymph node biopsies as well. As you can see, Che yesterday spoke about using it for leak tests and sleeves. I think ICG is an amazing, amazing tool. It's very cheap, and it could prevent a disastrous complication.
How about timing? Timing of it for gallbladders? What's your
Gallbladders as early as
protocol?
possible. We've given it on the table when they're in the OR, and let's say somebody forgot to give it in a pre-op area. We like to give it at least half an hour before.
Yeah.
And I've done it one time where I injected actually the gallbladder itself with ICG with the spinal needle because it wasn't really coming up too far up the cystic duct as much as I wanted to or in a common duct. So I put it in the gallbladder itself for a biliary colic patient, and their cystic duct was not obstructed, so it flowed right down, and it really helped out the case.
Yeah.
I have a comment on your experience when it comes to this, again, acute cases. So my experience when I'm doing this colectomies and or tough cases, long operative times, almost double, or I would just say it takes a long time. And
Yes.
the length of stay is not amazing. These folks stay in-house for quite some time. So what was your experience there? And do you collect data? When we collect this data, we look at this, there's no improvement in length of stay. And it just is tough. But I believe I'm doing better operation. I'm just satisfied. But I just want to see the big picture as well, because I become a selective bias, and I love the robot, and I truly believe I'm doing a better operation. But I would like to see, that has been my experience with the length of stay and some kind of length of the procedure. What has been yours and your group?
It's a very good question. So our elective colon cases definitely go home much earlier than our emergency colon cases, obviously. And robotically, if we're able to remove the specimen via the rectum for sigmoidectomies, we found that they go home a little earlier too, compared to our patients that we have to open up to take the specimen out. It was a very good question. These patients come in sick. They're going to stay in the hospital longer, whether you do it open or lap or robotic. But we found that if we're able to prevent a laparotomy incision in these patients, no matter if it takes longer in the OR, no matter if they still stay the same amount of time in the hospital, their wound infection rate is minimal, their dehiscence rate is minimal, and their pain is minimal. So at least they're up and getting around quicker. And we found that that's still a huge win if you're able to do a big operation and not have to do it open with the robot, no matter of the length of stay, because the long-term morbidity also will be less without that fascial incision.
Yeah, I agree. And we looked at this data for our colon patients compared to open and even the lap folks. And when we did it robotically, we looked at who went home versus who went to rehab. If you went home, who got home health services versus not needing home health services. And the robot was a win in every category. It was less than lap and open by far. And that's a huge downstream cost savings and benefit for our patients as well.
Great point.
I also have another thing I want to bring up. The ICG, I want to go back to that and pin you down on this a little bit. I'm an ICG addict. Gene and I both are. The worse the gallbladder, the more I love having ICG, honestly.
Yep.
Have you seen any accessory ducts? Like, what's your accessory duct rate? Because I think mine is about 1.7%. It's very high.
Mine's 0% because I haven't noticed any, to tell the truth. But I'm sure they're coming. I've heard from people like you and other surgeons have seen them. Ducts of Lushka. One of our current fellow had one in actually residency, a duct of Lushka leaking ICG, so they had to clip it. So I am looking for one, and if I do, that'll be the first one. But they are out there.
I've seen 17 now.
Yeah.
I don't know what that percentage is. Sorry, I can't do that math quickly.
But it's a pretty high number. It's
the more
way higher
you
than
look,
thought.
the more you see, obviously.
I mean,
Yeah, but the most important thing there with ICG is that there have been many times where I found the common hepatic duct or common bile duct right next to the cystic duct, and that might have been my common duct injury there. I'm not sure if it would have been or not if I didn't use ICG, but I'm happy I use it all the time for those types of cases.
You slept easier that night.
George, great comments on this. I mean, I think you guys probably from the first or pioneers when it comes to the acute care surgery. Not many folks can do this. Right now, you need a lot of group support, admin support to pull this off when it comes to very challenging cases. I mean, I truly believe that might be a potential in the future for acute care surgery, but that's where a lot of skill set needs to be kind of present. So what do you think in the next 10 years? Do you think robotics will have a kind of jump in acute care surgery, or do you think this is just a few pocket of expertise?
Oh, 100%. I mean, the amount of cases that we've done recently, for example, last week I've done a colovesical fistula, a large one where I took the guy to the OR and did it all robotically. I did a Hartman's also in a patient that's on chemotherapy, neutropenic with a white count of 0.2, and did that also robotically. And they did so much, they did so well. The more cases you do with these, the more comfortable you are with starting out robotic. You can always bail on the robot. You could try to look in laparoscopically, dock the robot, see whatever you can do. And if it's not safe, then you can just bail. But I think it's very important to have an administrator like Dr. Stiefman, a huge supporter in your practice yourself, like Dr. Pratt, Dr. Rosenstock, to help back you up. And then the nurses and the residents and the fellow, all just helps make the case so much smoother. But I do think in the next 10 years, robotic acute care surgery will be the next hot topic, after 24/7.
Awesome, George. Thanks, buddy.
Great talk.